way to measure astigmatism. I agree it's correct, but not entirely correct, and I'll tell you why. Automated keratometers are table supported and handheld. You have handheld autokeratometers also. You have optical biometers like your IOL Master, your Lens Star, and the new NIDEC AL scan. You have topographers like the Placido and the projection topographers, and you have the newer topographers like your OpScan, your Galilee, Pentacam, etc. And this is a list of all the instruments that we normally use. So if you ask me which one do I use them all, because there's a little bit of truth that comes from every instrument. You know that story of the elephant and 7 blind men? It's like that. Each one is correct in its own way. Each one measures a little different concept. And why is that important? Now, the manual keratometer, very briefly, tests your astigmatism at a 3 millimeter diameter from the center of your pupil. Now, this is achieved by a fluorescent light which is reflected like a convex mirror from your cornea. Every other instrument is basically dependent on this principle. Now, if you see the topographer, for example, it does not estimate the central 3 millimeters at all, because that is where your infrared source of light is. So your central 3 millimeters is always extrapolated in a topographer, and therefore your topographer is not the best instrument to calculate the magnitude of your astigmatism. It may be okay for verifying the axis, because nothing can be more accurate than that. And remember the words of one of my professors who taught me that in an aircraft, when it goes above the ground, there's one instrument which the pilot always has to look at, and that's the altimeter. That's the only instrument which is absolutely correct. Your topographer is like that. When you see a topography, you see the spread of astigmatism across the cornea. It shows where the astigmatism is in the 3 millimeter, 5 millimeter, 7 millimeter zone. But you cannot take it for the value of the astigmatism that it produces, because that is a sim K or a simulated K which takes the average of all the three. And our pupil sizes are not normally that broad. So if you keep on seeing the astigmatism as it naturally occurs, as you go to the periphery, it tends to widen up. So you cannot depend on that, and you look at more or less between the 3 to 5 millimeter zone. Your optical biometers are excellent because they come closer to the cornea. Wolfgang Hages taught us that central para-axial measurement of the corneal curvature is probably the most accurate method to look at it. Your automated keratometers measure at 3.3, your manual keratometers measure at 3, your optical biometers like the new IOL Master 700 as well as the Lens Star go not only measure at 2.3, they measure at 1.6 millimeters also. So you go so close to the center of the cornea that they are definitely more accurate. But have a heart for this little instrument which I possess, and which I think is one of the most wonderful instruments. It's a handheld autokeratometer. It goes in at 2.2 millimeters. And the beauty of this instrument is that it gives you very accurate keratometry. It's a very cheap instrument for a person who doesn't have an IOL Master. Very cheap instrument at 1.40 lakhs, you can't go wrong, okay? But the problem is it is handed. So if you have a pronation or a supination effect on your hand, your axis is not going to be very dependable. Now, why I'm saying this, I presume this is for people who are not using toric lenses before. So when you take the reading, it's very, very important to make sure that the patient is aligned properly. Every optometrist of mine are told not to be lazy. They have to walk behind the patient and see whether the head is positioned right. They have to see that the mark on the instrument coincides with the lateral canthus, not only on the right eye, but also on the left eye. You can be aligned one eye, and because of a head tilt, you're not aligned the other way. Cyclotorsion compensates for head tilt, but not always in all patients. You can go wrong on the axis. So it's very important to see the alignment of the head from the back as well as from the sides. And see, this is what might happen in case the patient is not looking in the right direction. If the patient is looking up, this, instead of being here, will be shifted upwards. So choosing the right K values. You've got so many instruments, which one will you take? Manual keratometers, still okay, not as good as the optical biometers. Handheld auto K is probably very reliable. It comes between the manual and the optical. And the topographers, as I said earlier, give a CME value, so it's not very right. Because you have to look at two variables. Just remember, it's a vector. You have to look at magnitude and you have to look at axis. Choosing the right axis. Optical biometers and table-mounted chin supporting. That means the patient's head is aligned properly, are probably very reliable as far as giving you the axis of the astigmatism is concerned. Handheld auto K is not so reliable. Now coming to the measurement of the lens. Now this is also important. You put a toric lens inside, you correct the astigmatism, and if you got a wrong IOL power because you didn't get a right action length, is no good. So you have to be right both ways, and therefore I want to caution you, just as important as it is to take the keratometer, measuring the action length is even probably more important. And of course, all of you know what these instruments are and what each of them does. The anterior chamber depth and the white to white bring a new dimension to the measurement of the IOL power. Because now, for the first time, you are trying to construct the eye as it is. Holiday taught us that there are 9 different types of eyes which are in the eye. From the long eyes with the short anterior segments to the short eyes with the long action lens. So there are 9 different types. So when you get the anterior chamber depth and the lens thickness, you are able to more effectively predict where is going to be the effective lens position. Remember, the eye has bimodal convergence. You have a cornea bending 75% of the light, you have your retina here. This is going to take care of only 25% of your refraction. If your lens is positioned anteriorly, you require a lower IOL power. If your lens is positioned posteriorly, you require a higher IOL power. So if you are able to predict beforehand where the lens is going to rest, then that's more accurate. That's a combination of your anterior chamber depth